Okay, so I'm going to cover chest trauma, pneumothorax, hemothorax here. There's two types of chest trauma, blunt or penetrating, and the result of a blow to a chest, blunt trauma damages internal organs without breaking the skin. And because you can't see these injuries, they're kind of hard to find. You're going to suspect blunt trauma like in a motor vehicle accident or injury in a fight, contact sports, a fall, something blunt happened. Damage caused by that blunt trauma depends on the type of injury. In a deceleration injury, for example, a patient's traveling in a car, high speed, comes to abrupt stop, hits his chest on the steering wheel, and he can suffer from a rib fracture, aortic tear, flailed chest, that kind of thing. The diagnosis is made on the basis of symptoms and a chest film. 4 out of 5 patients who have an aortic tear, they don't even get to the ER. A compression injury are ruptures that result from sudden pressure. And it's kind of like popping a paper bag that you just filled with air. Like the patient or the victim is in the car anticipating the impact of the car crash, and they like inhale and hold their breath, and that can cause a tension pneumothorax or a myocardial contusion. So open and penetrating wounds, trauma, typically gunshot or knife. These injuries are obvious because they're easier to assess. You see them. There's several factors that you have to consider. What weapon was used. It determines the damage sustained from the penetrating trauma. The severity of a gunshot wound depends on the ammunition and the gun, the angle and the distance from where it was fired, and the time that's elapsed since this injury occurred. With a handgun, usually the damage it's only in a direct path, and like in a shotgun, there's it's a blast with pellets, and it can expand and cause multiple injuries. Stab wounds, the damage is due to the length and type of weapon, the depth and the angle of insertion, and surprisingly enough, the gender of the assailant, because men usually stab underhand and upward, and women are overhand and downward. So that's interesting. Little piece of trivia for you. So what do we see? We see dyspnea, respiratory distress, cough with or without hemoptysis, cyanosis of the mouth, face, nail beds, mucous membranes, tracheal deviation, audible air escaping from a chest wound, that would be called a sucking chest wound, decreased breath sounds on the injury side, decreased O2 saturation, and frothy secretions. Cardiovascular findings we'll see is a thready, rapid pulse, decreased blood pressure, a narrowed pulse pressure, asymmetric blood pressure from arm to arm. We see distended neck veins, muffled heart tones, chest pain, crunching sounds that are synchronous with the heart sounds when we're listening to their heart. That will tell us that there's broken ribs in there. And arrhythmias. When we look at them visually, we're going to see bruising, abrasions, an open chest wound, asymmetric movement, and they could have subcutaneous emphysema. I'm going to go over that in class. And also look for an exit wound if there was a gunshot. Okay, so this would be an emergency situation, obviously, and our interventions are concurrent with our assessment. So we're not just looking at them, thinking about it, and then doing these things. We're doing this while we're assessing. We're going to check and treat ABCs. Therefore, we're going to ensure a patent airway. We're going to give high flow O2 with a non-rebreather mask. We're not going to care if they have COPD. We're going to give them, or whatever. We're going to give them high flow O2. We're going to establish an IV with 2 large bore catheters. We're going to begin any kind of fluid resuscitation, send off for a cross match, give them blood if needed. We're going to remove their clothing so we can assess their injury. We cut the clothing off these patients We don't worry about saving anything, we just cut it right off. We cover a sucking chest wound with a non-porous dressing taped on 3 sides only, and that is to allow air to escape but not to suck in, because we do not want to put air in that pleural space. We want it to exit, but we don't want it to go in. We stabilize any impaled objects with a bulky dressing. If there is a knife sticking out of their body, we do not pull it out. We just stabilize it. We assess for other significant injuries and treat appropriately. We stabilize a flail rib segment with our hand or large pieces of tape so that it won't suck in and out. And put the patient in semi-Fowlers or position them on the injured side if breathing is easier once we have stabilized, made sure that they don't have a spine injury. We'll turn them. And of course monitor all their vital signs, level of consciousness, cardiac rhythm, respiratory status, and watch their urine output as well. A pneumothorax is defined as air within the pleural space, and this air can cause partial or complete lung collapse. There's 2 types of pneumos, open and closed, and the diagnosis is confirmed by chest x-ray. An open pneumothorax occurs when an opening is in the outer chest wall and allows air to enter the pleural space. With an open pneumo, it can be due to damage either the partial pleura or both pleural membranes. This damage can be a result of chest trauma, like I just talked about, stabbing or gunshot wounds, fractured ribs, possibly from CPR or trauma, industrial accidents, intentional during thoracic surgery. We create a pneumothorax, so that's iatrogenic. A diagnosis is confirmed by the physician through chest film and blood gases, and the amount of lung collapse is identified as a percentage. 35% would be a partial collapse, and typically they treat that with a one-way flutter valve called a Heimlich, to correct the collapse. A closed or a spontaneous pneumothorax occurs when the outer wall or the parietal pleural remain intact, but the injured visceral pleura allows air to escape into that pleural space, that potential space. Iatrogenic cause of a pneumothorax is when we've created that, and that happens during a lung biopsy. We could do it with a thoracentesis, placement of a Swan-Ganz catheter, a central venous catheter. It can happen during endotracheal intubation, just to our few. Obese patients tend to be more at risk for this because their anatomical landmarks are difficult to find because of the extra adipose tissue. So when we do our nursing assessment of a patient with a pneumothorax, we're going to look for shortness of breath, increased respiration, their tachypnea, a falling pulse oximetry, so we're losing our O2 sats, loss of breath sounds on the affective side. We're going to palpate for subcutaneous emphysema or crepitus. There will be hyperresonance with percussion, and that's a late sign. And there will be lack of movement on that affective side when we looked at him. As a nurse, you have to assess lung fields and do comparative assessment. So we look at inspection, auscultation, palpation, and percussion of all lung fields, and we're going to document any abnormality. The chest film will confirm the lung collapse. Prompt identification and treatment of a pneumothorax is of great importance. Failure to treat this may result in a life-threatening problem. Attention pneumothorax is an injurious condition which occurs when the air is allowed to escape into the pleural space during inspiration, but it cannot escape during expiration. This increases with each inspiration, and the positive pressure rises and forces this shift of the mediastinum, the trachea, and the larynx to the opposite side of the collapsed lung. The patient will complain of sharp pleuritic pain. This is life-threatening. Their blood pressure drops because of the compression on the vessels. We'll see distended neck veins. Their respiratory status will become very impaired. We'll see arrhythmias. If this is untreated or unrecognized, it can lead to cardiac arrest and ultimately death. Because what happens is the other lung becomes compressed and causes so much pressure. So this is diagnosis with chest x-ray, and it's treated by placing a chest tube in place. And then we're going to do ongoing assessment, airway maintenance, oxygenation, monitor cardiac output and blood pressure. A hemothorax is defined as blood within the pleural space. So how does that blood get in there? Well, most common is because of a trauma, maybe from a car accident or a fall or a gunshot or a stab, or it could be from anticoagulant therapy. Anyways, it is confirmed by chest film, and we put a chest tube in. And in the case of like heart surgery where they have it's intentional that they went into that space, they can auto-transfuse that blood. Auto-transfusion is the collection and filtration and reinfusion of the patient's own blood, so they could do that. A pleural effusion is the accumulation of fluid within the pleural space that compresses the lung. That's a pleural effusion. And we will see decreased or absent breath sounds, less defined intercostal spaces on the affected side, and respiratory difficulties. A cardiac tamponade is the accumulation of blood or fluid around the heart, and that's either in the within either the mediastinum or specifically within the pericardial sac. And really what happens there is the heart is literally squeezed so it cannot expand to accept venous return and decrease cardiac output results. A cardiac tamponade, I didn't even know I was going to go into this, but I will. Let's see. A cardiac tamponade, you're going to see decreased venous return, increased central venous pressure, decreased blood pressure, JVD, and eventually the patient would go into pulseless electrical dissociation, cardiac arrest, and death. So we need to do a pericardial centesis. Early changes for hemothorax and a pleural effusion is if a patient all of a sudden begins to show respiratory distress with an increased respiratory rate, shallow breathing, loss of breath sounds. This is an emergency situation.